Hola, buenas noches a todos. Muchísimas gracias por estar nuevamente aquí con nosotros en esta sesión mensual. El día de hoy hablaremos sobre la evolución de la adquisición de tejido por ultrasonido endoscópico, consejos del experto. El día de hoy nos acompaña nuestro experto nacional, el doctor Luis Ariel Waller González, y como nuestro experto internacional, el doctor Anand Sahai, de Quebec, Canadá. A continuación, la doctora Katia Picasso nos hará una breve introducción sobre nuestro profesor internacional.
Buenas noches, pues realmente es para nosotros un gusto poder contar con la presencia del doctor Anand Sahai. El doctor es jefe de la división de gastroenterología en el Hospital de Montreal. Es un líder mundial reconocido a nivel de ultrasonido endoscópico. Ha recibido múltiples premios por parte de la ASG en proyectos de ultrasonido endoscópico y también es uno de los pioneros y que cuenta con un curso de ultrasonido endoscópico. En su centro hacen más de 2.600 ultrasonidos al año, lo que lo ha posicionado como un curso de gran interés para varias personas a nivel mundial. Y vamos a empezar con su presentación.
Hey, thank you for your very kind invitation. Today I'll be discussing the evolution of endoscopic ultrasound tissue acquisition, expert tips. Here are my disclosures. So the objectives, one, to understand the variables associated with successful EUS-guided tissue acquisition, and two, to understand the role of FNA versus FNB, fine needle aspiration versus fine needle biopsy. So the plan, I'll go over the expected yield these days based on the available data, FNA versus FNB pros and cons. I think it's important to stress the difference between scraping and cutting needles, and then go over how to maximize the yield of FNA and FNB. So the take-home points, one, due to the development of cutting FNB needles, the issue of EUS-guided tissue acquisition has been solved. Suboptimal results are not due to the device, but they are due to poor technique. You must move the needle adequately and broadly within the target lesion with the needle of choice. This is the most important thing to do. The techniques for maximizing the yield of FNA and FNB are the same. ROSE, or rapid on-site evaluation, may still be helpful for FNA, but is not needed for FNB. So just to look at this meta-analysis, an early meta-analysis showing that for FNA cytology of pancreatic masses, you should be getting at least approximately 90% sensitivity. If you're not getting this, there's a problem. That being said, for cytology, there are easy cases and hard cases. So the easy cases are the obvious cancers, large masses and nodes, large SMTs. And for these types of cases, I think you really should be getting more than 95% sensitivity with your biopsies. And if you're not, I think the problem is probably with your technique. Then there are obviously harder cases, questionable masses that are hard to see within, for example, chronic pancreatitis. Autoimmune pancreatitis has been a problem for FNA needles, smaller lesions, mobile lesions, difficult positions, and the presence of metal stents can also cause problems. So is FNA sufficient for most people? Most EUS FNA is for the diagnosis of epithelial cancers, and ancillary tests are needed in a minority of cases. Believe it or not, there is no convincing evidence that getting a core increases the diagnostic yield for epithelial cancer, which is what we deal with most of the time in EUS FNA. FNB, however, may reduce the number of passes to get an adequate sample. So the question I would ask for people who are asking to get FNA versus FNB, instead of using a more expensive FNB needle, why not just do another pass with your FNA needle and get a cell block? If you look at what you can get in terms of analysis with a cell block compared to core biopsy, it's pretty much all the same except for the cell structure. So if cost is an issue for you, I think FNA with a cell block can almost always replace FNB with a core sample. So FNA versus FNB, why get a core? Well, if your pathologist simply is not good at cytology, this may be an issue and you may need to get a core. If you truly do need structure, for example, lymphoma, autoimmune pancreatitis, etc., and obviously for liver biopsy, which is beyond the scope of this talk. And then in cases where you have failed cytology, a dry pass, you're just getting not enough tissue. Examples, linitis plastica, particularly sclerotic tumors, small SMTs, although we could ask whether it's really useful to biopsy such lesions. Anyway, in cases where you're not getting adequate tissue with the FNA needle, then FNB may be a solution. And then if you do not have access to rapid on-site cytology, then FNB may solve this issue as well. When we switched to FNB, we started to see some unforeseen benefits. We were getting great results with FNA, but when we switched to FNB, there were some really interesting findings. First of all, in cases where we had several negative FNA samples, we would get a positive negative result in the sense that not only would we show there was no cancer, but the FNB with the core tissue showed us a benign pathology that kind of answered the clinical question. So we found chronic pancreatitis or autoimmune pancreatitis, or in, for example, mediastinal nodes, we found things like silicosis. So when FNA is negative, you never know if it's because it's a false negative. But with FNB, you get no cancer when it's negative, but you also get often presence of a true histological diagnosis of a benign condition, which can reduce the need for repeat biopsy. And then surprise positives in cases where there are well-differentiated tumors, for example, in malignant transformation of IPMN, we found a few cases where several FNAs were negative, but then the FNB showed a surprise well-differentiated cancer. And then when you do FNB, you are doing true histology, so you do get a complete pathology report, including all the genetic markers and things like that. You can get those with the cell block with FNA, but you really do get a serious pathology report when you do core biopsies. Why not get a core? Well, basically the only reason, in my opinion, is money. So these needles, certainly in Canada, are almost twice the price of FNA needles, but we found that because of the increased accuracy, the reduced false negatives, the reduced need for repeat biopsies, in the end, it probably ends up being cost effective. That being said, if you can't really afford to use an FNB needle, we used initially a protocol where we used FNA for standard easy cases, but in selected cases where we had known difficulties with FNA, we did try and use FNB in those cases. And in these cases, we found that when we selected out the difficult cases, such as linitis plastica, sclerotic tumors, things like that, the sensitivity for malignancy was still very high, over 90%, and these were all obtained without rows. So in our center, the 22 gauge Francine tip needle was an excellent choice in cases where traditional FNA was generally inadequate. So it may be a way to reduce the cost by using FNA for most easy cases, but reserving the FNB for difficult cases. Now the concept of scraping versus cutting needles. The original, in quotation, core needle was the reverse bevel needle. The problem with this needle is that it doesn't really cut very well. It's not very sharp, and it tends to scrape tissue into the needle. And the result is that you get very bloody samples like this, and it can be hard to distinguish cores of blood from cores of actual tissue. The new cutting needles, as you can see, are very sharp, and they cut excellently into tissue. And as you can see the clear difference in the samples that we get. This is an example of just on a slide here. There's so much tissue here and there's no blood, so you can clearly see that you've got tumor tissue. Same thing on the right in the formalin. And so this really allows you to do macroscopic on-site evaluation much better because you minimize the amount of blood and you can clearly see the amount of tissue that you're getting. And look at the amount of tissue. On the left-hand side, there's so much tissue there that you can't even do cytology. You have to take a small amount of it and put it on a slide and smear that itself if you want to do cytology because you get so much tissue. And this is just one pass in each case. Sham Vardarajulu compared directly FNA and FNB needles, And just to show you that the accuracy and specimen adequacy was clearly higher with FNB versus FNA. So I think it's clear that these needles provide better tissue acquisition results. And then I think this interesting study compared the Francine tip needle to the 20 gauge reverse bevel needle, and also clearly showed that the cutting needle was clearly better than the scraping needle for both adequacy and accuracy. So I think that really puts the nail in the coffin for the scraping needles. It's clear to me that the cutting needles are the needles of choice for FNB. So how do we maximize the yield of FNA and FNB? As I told you, the techniques are the same. The needles are 22 gauge needles. They're quite flexible. They're easy to use. So the variables that do impact the yield of FNA and FNB are as follows. Obviously, who is doing it? If the operator is not very experienced, cannot get the needle in the lesion, that's an issue. And then your cytologist or your pathologist, if they are not very comfortable with looking at EUS specimens, that may affect your accuracy. Lesion types, as I say, some lesions are more difficult than others to penetrate, to sample. Lesion location may also inhibit your ability to adequately put the needle in the lesion and move it adequately. And then in certain situations, if you don't have access to the lesion because of postoperative anatomy, I think metal stenting can be an issue. Certainly if the air from the stent prevents you from seeing the stricture, particularly in small lesions. And the presence of chemo-XRT, radiotherapy, can be an issue for the pathologist in distinguishing cancer from radiation-induced changes. I think the most important variable, though, is how you sample. If you can imagine the pancreatic duct here, a pancreatic duct stricture, and a tumor seen on EUS, you have to remember that the actual lesion, the actual cancer, may be actually quite small, and a lot of what you're seeing on EUS can be obstructive pancreatitis. So I think it's really important to focus, to sample widely, to increase your chances of actually hitting what is the cancer focus. And if you don't see a lesion very well, I recommend you focus on where the stricture is or where you see aggressive behavior such as vascular invasion. That's where you're most likely to find the actual focus of malignancy. I think people now generally accept that the concept of sampling widely in the lesion is very important. I'd just like to distinguish between the concept of fanning, where you go through the wall once into the lesion and try and, without coming out of the lesion, try and reorient yourself in different parts of the lesion. I find this can be very difficult in hard lesions, so it's harder to sample widely using this technique. We use a multi-pass technique where we actually go into the lesion in one area, come completely out, and then go somewhere else. And this allows us to really sample widely because we're not limited by being stuck inside the lesion. We've refined this technique now. Instead of going through the wall multiple times, we go through the wall once. And if there's room in between the tumor and the wall, we'll pull the needle out of the lesion, move over with the elevator or the up-down, and then go back in somewhere else. This helps minimize contamination of the sample with wall tissue. So this is a multi-pass technique with minimal wall tissue contamination. Size of the needle does appear to be important. So smaller needles, I think, are better because they're easier to manipulate. Because they're smaller, I think they're easier to push through the lesion. They give you less blood because they have less capillary effect and just give you they have more capillary effect, but they still give you less blood in the samples. The 19 gauge needle is of no value for cytology. It's only good for liver biopsy, in my opinion. For FNA, the 25 gauge needle is better than the 22 gauge needle. As I say, it gives less bloody samples and increased accuracy generally. And for FNB, the 25 gauge FNB needle does not provide good cores. It is a great cytology needle, but for cores, I think you really need to use the 22 gauge needle, and there's no advantage to the 19 gauge FNB needle. And in Canada anyway, the 19 gauge FNB needle is 4 times the price of the 22 gauge FNB needle because the 19 gauge needle is made of nitinol. So here's just some data showing that in a meta-analysis The 25 gauge needle does appear to be better than the 22 gauge. As I think it's partly because the 25 gauge is easier to manipulate and easier to move inside the tumor, and it also provides less bloody samples. Is it good to get on-site cytology? I think if you sample widely, I don't think it really increases the yield of a multi-pass technique. But if you can, I think most people who have on-site cytology would never get rid of it. You get a rapid response. It saves a number of passes. It lets you know immediately in the case of cytology where there's supplementary testing is needed. So if a cell block is helpful, I think it's particularly good for pancreatic lesion and for lesions where tumor seeding is a concern. For example, pancreatic body lesions where the biopsy tract does not come out with surgery. If you want to reduce the number of passes, having on-site cytology can be helpful. We don't use it we don't use it anymore because we use primarily FNB, but if you're doing multiple nodes and just trying to get tissue, I don't think it's really helpful. For SMTs, we don't use it as well. And for low probability lesions, we do not call the cytologist. Here's just some data showing that generally, when you had on-site pathology versus no on-site pathology, the results clearly appeared to be better in many centers. For FNB, however, this nice study showed that adding rows to FNB with macroscopic evaluation of the sample, so MOES, macroscopic on-site evaluation, if you can see the cores on FNB, adding rows was of no value. So for FNB, if you can see the core tissue adequately, adding rows is of no value. Things that do not impact the yield of FNA, sample preparation, or FNB in that matter, suction, stylet, and needle type, we're talking about FNA there. So suction versus no suction, when you look at the studies that compared suction to no suction, and so suction was better, the problem with these studies is that the control group provided very low, unusually low accuracy. So I think in these studies, basically, the operators didn't try as hard in the no suction group, and they artificially increased the value of suction. In my experience, suction simply provides more blood without increasing accuracy. And I guess we never use suction unless we get a dry tap. My question to people is, if I don't need suction, why do you need suction? Basically, if you move the needle widely in the lesion and aggressively, you don't need suction, and you'll get less blood, and you'll get better macroscopic evaluation of your tissue samples. When you actually measure the amount of suction at the tip of the needle with different size syringes and with the slow pull technique, just to show you that the slow pull technique here, which is all these almost no suction, is essentially no suction. So in my opinion, slow pull is the same thing as no suction. It is a waste of time. The only reason slow pull provides better results is because people sample more widely and longer as they pull out the stylet. So doing slow pull to me is the same thing as no suction, so you may as well just stop doing slow pull. It's a waste of time. We were the first to show that using the stylet is of no value. In this randomized study, we had no difference in accuracy with the stylet, and there was no increase in false positives due to wall tissue contamination. So the stylet is also unnecessary. Since that time, there have been several randomized trials, and there's not one single randomized trial showing any value for the stylet. So I encourage you to stop using the stylet. In fact, I think the stylet, if you use it on your first pass, it actually prevents tissue from getting in the needle. And when you pull back the stylet quickly, you do aspirate a little bit of blood. So it just makes your samples more bloody. So I encourage you to try doing your FNAs without stylet. So how to maximize the yield of FNA and FNB? Use a multi-pass technique, and I recommend trying to use the minimize wall contamination technique. Sample very widely all through the lesion from one side to the other in as many places as possible, filling the needle with tissue in your first pass. If you're doing FNA, use a 25 gauge needle. Make slides and a cell block if needed, and if you can, get a cytologist in the room. For FNB needles, use a 25 gauge cutting needle, a 22 gauge, cutting needle, and use macroscopic on-site evaluation, not rows. If you do not use suction, you will be able to do better MOES because you will have less blood. And suction, including the slow pull and the stylet, are not necessary and needlessly waste time. And putting the stylet back in the needle increases the risk of needle stick injury for your nurses. So I strongly encourage you to try doing FNA without suction, without the stylet. You'll see your procedure will be much faster, and your staff will be very appreciated of the less work they need to do. And as I say, excess blood with suction makes Mohs more difficult. So FNA versus FNB, state of the art, where are we? We know that fine needle aspiration, FNA works well, is cheaper than FNB, and is sufficient in many cases. If you need a core now, though, you can truly get a core with greater than 95% success. And I think people who have access to both FNA and FNB are migrating to core. It has unforeseen benefits and obviates rows. And really provides you just with amazing samples now with no need for the pathologist. But core needles are not all equal. We have cytology FNA needles, and then we have scraping FNB needles and cutting FNB needles. So standard cytology needles, the 25 gauge is fine, but for cores, you really need to use a cutting needle instead of a scraping needle to get the best results. And with that, I thank you for your kind attention, and we hope to see you sometime in Montreal. Hopefully, this is our Canadian EUS meeting, which will be held this year in Toronto on October 13th and 14th. You can find more information at www.eusfocus.ca, and I hope you have a great rest of your meeting. Take care.
Buenas noches. Doctor Sahai, muchísimas gracias por su excelente presentación y muchísimas gracias por estar conectado en vivo con nosotros para esta sesión de preguntas. Cedo la palabra al doctor Rodrigo Soto.
Hola Anand, qué gusto saludarte. Muchas gracias por aceptar nuestra invitación.
Hola, Rodrigo. It's very nice to see you.
Me da mucho gusto verlos. Ya tienes barba. Sí, nos faltan unos cuantos tragos, vodka o lo que sea.
Muy interesante la evolución de tejido, la evolución de adquisición de tejido que ha habido. En México seguimos con pocos centros que puedan hacer biopsias por ultrasonido endoscópico. Cada vez han ido aumentando y sí vemos un gran beneficio del tomar biopsias con aguja de corte con respecto a las antiguas para los patólogos, que creo que es algo importante que señalaste, y realmente tampoco le vemos utilidad a la aguja 25. Escuché en tu plática que la 19 tampoco te parece que hace la diferencia. ¿En lesiones subepiteliales crees que tenga algún valor?
So you're talking about FNA needle, not FNB, right?
Not FNB needle, 19 gauge for SMTs?
La de 19.
Okay, 19 gauge FNB needle.
Yes.
Okay, so the data seem to show that the 19 gauge FNB needle is very good for liver biopsy. There are not a lot of data on the 19 gauge FNB, and I'm talking about, when I talk about FNB, I'm talking about the cutting needle, not the scraping needle. So out of the fork tip needle or the Francine tip needle, there are not a lot of data on SMTs, but I don't see an advantage of the 19 gauge over the 22 gauge for any solid lesion. And as I say, the 19 gauge is, in Canada, it's 4 times the price because it's made of nitinol. So it's very expensive. So I really recommend that for all solid lesions, you use the 22 gauge FNB needle.
¿Has tenido oportunidad de utilizar la biopsia quiste y te parece que tiene algún valor como
the clamp, and
tomamos
do you think
biopsias
that there's any
de
value
neoplasias quísticas
when
pancreáticas.
taking biopsies of pancreatic cystic neoplasias?
So if I understand, is there any advantage of using the FNB for cystic lesions?
No, the Murray forceps.
Oh, the Moray. So,
Yeah.
so see, the problem for me, Rodrigo, is that I think I'm a bit of an outlier when it comes to sampling cystic lesions. We sample less than 10% of cystic lesions because there are a lot of data showing that sampling cystic lesions changes management. Okay, it changes people's decisions, but there are zero data showing that it actually improves outcomes. So my feeling is that many times people sample lesions and they make surgical decisions based on this, but there's no data showing that the patients that we select by this method do better clinically. And as you know, more and more patients we see are quite old. And I fear that by finding, for example, dysplasia, things like that, we are subjecting older patients to quite invasive surgery. And it's really not improving their quality of life or their survival. So just to say, I rarely sample cystic lesions. So the Moray needle, Moray forceps, I think I've used it once at a course. We don't use it in our institution, but my feeling is if you are going to sample a cystic lesion in the wall, you really should focus on only the thickened part because it also tends to bleed a lot when you touch the cyst wall. And my feeling is that with the good FNB needles, the cutting needles, you will probably just get as good samples as with the Moray. That's my feeling.
Mencionaste durante tu plática que
During your
cuando
talk,
no
you
es
mentioned
clara dónde está la
that
lesión,
when
hay que
the
apuntar
lesion is
hacia la
not
estenosis
clearly
y a la región de
established,
invasión
we have
vascular.
to focus on
A muchos de los que
stenosis
hacemos
and
ultrasonido endoscópico nos da miedo biopsiar cerca de la
region.
invasión vascular.
Many of us who
¿Crees que
do
realmente hay
ultrasound
algún
are
riesgo
afraid
añadido
to
con
do
las
this
agujas
close
nuevas en
to
cuestión
the
de
lesion? Do
hemorragia?
you
Por
think that
ahí
there's
hay
any
algunos
risk in
artículos
terms
que lo
of
mencionan.
hemorrhage? There are some papers that mention this.
Okay, so I'm having a bit of a problem because I hear you as louder than the translator.
Okay.
So maybe you could repeat the question.
You mentioned in your presentation that if you can see the lesion clearly, you should aim for the stenosis or the vascular invasion region. I think
Yes.
a lot of people that do US think that going into the vascular invasion could cause some problems. Do you have any bleeding in this kind of behavior?
Yeah, so I understand that, but you must understand when the vessel is encased, even if you go into the vessel, there's nowhere for it to bleed. So it's really, really quite safe, to be honest. And even when you go into the portal vein and things like that, it's surprising you don't get much bleeding. And I would tell people when you're doing FNA or FNB, oftentimes you see bleeding between the pancreas and the gastric wall or sometimes the duodenal wall. And it can look quite frightening. It looks large, but most of the time if you measure the size of the clot, it's about 2 centimeters, 3 centimeters. And what I tell the fellows is like, when you see bleeding, don't take any pictures, just send the patient home. That's it, because I've been doing it for so many years now, and I've seen some very scary looking bleeding, and it just doesn't seem to be a problem. It stops, we send the patients home, and they do fine. Now, if you see active bleeding with like a vessel, spurting, you might want to observe the patient. I think I had once or twice that happen in a cystic lesion. And even those patients, we sent them to angiography and they never found where it was bleeding. So fortunately, it would appear that the bleeding from EUS FNA or FNB can look dangerous, but clinically it's really not significant. I've heard of one death from somebody who lacerated, I think, the gastroduodenal artery. So I would say, though, going into a vessel, perpendicular is safe, and it's actually quite hard to put a needle into an artery. They move, and the wall is very muscular. It's quite hard to put a needle into an artery. But if you are close to a vessel, avoid lacerating going to the side of the vessel. That's where I think it can be dangerous. It can be dangerous. And if you see a vessel in front of you, what you can do is you can turn the ultrasound away from the vessel, put the needle through the wall and past the vessel, and then turn back, and the needle will actually push the vessel to the side, and then you can go into the lesion.
Dr. Waller, any comments or questions that they may have in the audience? Very interesting what you've said, Doctor. I do recall having a case where a patient died with very significant and abundant bleeding. I've been doing this for 8 years, and I'm still afraid sometimes.
It's good to be afraid. But in the end, as I say, I've been doing for 25 years, and I don't recall having bleeding from an FNB that was clinically significant in a solid lesion. I had one major bleed during a celiac plexus block where I lacerated the adrenal artery in a patient that was anticoagulated. That was really not good. So she did okay until she restarted her anticoagulation, and then she went into shock. But they managed to embolize it, and she was okay. So it's really exceptionally rare. It's really not a major problem. And by the way, if they're anticoagulated, the patients, obviously we tell them to stop. And I always tell them after I do the biopsy to start the next day, not the same day, the next day. And it's been quite safe. And in some cases, if patients are anticoagulated because they have a major pulmonary embolus or something very dangerous, I will sometimes do the biopsy even while they're anticoagulated, especially if it's in the duodenum, because there's not much room to bleed. Or, sometimes, and in those cases, I might take a 25 gauge needle, and I might, if we were doing cytology, I would try to have the pathologist there to minimize the number of passes. So I think it's somebody who's anticoagulated. If you really need to keep the anticoagulation, I would probably use a 25 gauge FNA needle and just do FNA. No, I wouldn't use an FNB needle, a cutting needle.
Doctor, ¿le encuentra alguna utilidad para estos casos que mencionó como casos difíciles? Por ejemplo, en pancreatitis crónica, el uso como de tecnologías como la elastografía o los contrastes para dirigir las biopsias.
So this is an interesting question, because I know many people live and die by elasto and contrast. I will tell you, and Rodrigo can probably tell you, I never use it. The contrast, I think, is useful in some limited indications, particularly after RFA, to verify whether the lesion has been completely destroyed. But I think elasto and contrast, particularly elasto, was interesting at a time when there were indeterminate biopsy cases. But now the FNB is so good, there are almost no more indeterminate cases. And if you look at the live courses that people who do elastography, it never prevents the biopsy. They still do the biopsy anyway. And the problem with the elastography also is that the studies for elastography are very flawed, in my opinion. One, because you're never blinded to the B mode image. So you see a huge pancreatic mass that looks obviously like a cancer, And then they put the elasto and they go, oh, look, it's blue. It's very blue. See, it's blue as well, but it's obvious it's going to be blue. It's like pancreatic cancer. And so, and also in the studies where they assess elasto, the average accuracy is about 80%. So 80% in cancer patients is unacceptable. That's a 1 in 5 chance of being wrong. You can't be 20% wrong in cancer patients. And that is in those studies also where they're getting 80%, they are flawed because in those studies, they should be including only indeterminate cases. That's the true study population where it needs to be tested. But in those studies, they include patients with obvious cancers where the biopsy is positive, and they include patients who have obvious benign disease. So it's for sure the accuracy in those patients is going to be quite high, and it gives you overall an accuracy of 80%. But if you selected out just the cases that were indeterminate, I guarantee you the accuracy would be 50%, which is the same thing as flipping a coin. So I think elasto will be interesting for non-cancer situations, such as fibrosis, chronic pancreatitis, particularly now with the histogram, which is not operator dependent, I think. It's less operator dependent, and for evaluating liver fibrosis. But for cancer, I think it's a waste of time.
Multipass y
The
cómo se han
scanning
ido
technique and
perfeccionando.
multipass.
¿Te parece
And
que
how it has
necesitamos
been
hacer
perfected.
tanto estas técnicas con las nuevas agujas? Mi
With
perspectiva
the
es
new
que
needles, we
estas
can
nuevas
do
agujas
these
son tan
techniques.
buenas que con menos pases tenemos buena muestra.
Maybe these needles are so good that with less passes, we can even get a good sample. Is that correct?
Yeah, the question is, you always get a good sample if you move the needle completely through the lesion. Wherever you put the needle, you will get a good sample. The advantage of the multipass is that if as I say, the mass is big, but the tumor is very small, the actual cancer is small, by doing a multipass, you increase the chances of actually putting the needle through the tumor. That's why I think it's good to go in many different places. And I recommend that you do the first pass in one station, and if possible, before taking the needle out, go to a different station, or for the second pass, go to a different station and biopsy from a different station, because to me, it's like you're getting a different view of the lesion, like radiology. So if you biopsy from different stations, you increase the likelihood of getting a diagnosis. This is primarily for cytology if you don't have on-site cytology. Now, with the FNB needles, because you can see the core, the white tissue, you know when you have cancer now. And the studies seem to show that as well. I showed you one study from Alberto Larghi that there was no advantage to adding rows to just a macroscopic evaluation of the sample. And I really insist, stop using suction, because when you use suction, you get more blood, and it makes the macroscopic evaluation more difficult, because it's more difficult to distinguish a blood core from true tissue core.
Are you still using rows for all cases in your?
Yeah, so we use only FNB now. And so because we use FNB, we never call the cytologist anymore. So the cytologist you saw, he retired, and we never see him anymore. And the other girl who replaced him, she used to come all the time. And then as soon as we got the FNB needle, we just stopped calling her. And I haven't seen her in like 5 years. It's crazy.
Any further questions, Dr. Weller?
Creo que se perdió. Anand, it was great having you with us. I still wanting that you come to Mexico for a live case, or perhaps to Spain.
Yeah, I was honored to be here, and I would love to see you and all your colleagues anywhere, anytime, Mexico or elsewhere.
Great.
All right.
Bueno, pues muchísimas gracias a todos por haber estado conectado con nosotros.
Well, thank you
Muchísimas
very
gracias
much
a
for
nuestros coordinadores.
connecting to this
Doctor
Q&A.
Waller,
Thank you,
muchísimas gracias por
our
haber estado
coordinator.
conectado.
Dr.
Y
Waller,
esperemos
thank you very
pronto
much
verlo
for
por acá,
being
por la Ciudad de
connected,
México,
and hopefully
doctor
we
Sahai.
will be able to see you here in Mexico City. Thank you very much.
Okay.
Bye.
Hasta luego. Bye.
Ok, muchísimas gracias a todos por haber estado conectados en esta noche lluviosa aquí en la
Thank
Ciudad
you
de
very
México.
much
Y
for
por
being
último, tenemos todo lo que son nuestras
connected
actividades
in Mexico
académicas
City.
AMEG. Ya se encuentra cerca nuestro gran evento académico presencial, Ecos Endoscópicos Internacionales, que se llevarán a cabo del 20 al 22 de julio en el Hospital Español en esta ciudad, con reconocimiento del Consejo Mexicano con valor de 25.5 puntos para la recertificación. Los esperamos. Las inscripciones al correo ameg@endoscopia.org.mx. También, como los invitamos al curso Actualización en el abordaje endoscópico avanzado del intestino delgado, el cual vamos a llevar a cabo el 11 y 12 de agosto de este año, en el cual contaremos con expertos nacionales e internacionales y tendrá un reconocimiento por el Consejo Mexicano con un valor de 12.75 puntos para la recertificación. Igual las inscripciones e informes al mismo correo. Consulta ya la convocatoria para el registro de candidatos a vicepresidente y subtesorero del 2023-2024, que se encuentra en la página web de la asociación. No te pierdas nuestra reunión nacional de endoscopía, que se llevará a cabo del 21 al 25 de septiembre del 2023. Consulta el programa académico en nuestra página web de lo que es el curso de posgrado, Congreso AMEG, y también habrá un curso latinoamericano de intestino delgado, así como un curso de AMETED y hands-on. Te invitamos a responder lo que es la encuesta para el Consejo AMEG en intestino delgado, cápsula endoscópica y enteroscopía asistida por dispositivos, la cual tiene una finalidad de conocer lo que es el censo de médicos especialistas en gastroenterología, cirugía general, medicina interna y endoscopía gastrointestinal, que realizan estudios de enteroscopía y cápsula endoscópica y que se encuentran interesados en participar en este consenso de intestino delgado organizado por esta asociación. Por último, esperamos su asistencia a nuestra próxima sesión mensual, que se llevará a cabo el 10 de agosto del 2023 con el tema enteroanastomosis guiada por ultrasonido, con el profesor internacional invitado, Dr. Anthony Teo Jun Bun, director adjunto de endoscopía y profesor asociado en la Universidad de China de Hong Kong. Recuerden todos los socios ponerse al corriente para obtener todos los beneficios de nuestra asociación. Muchísimas gracias a todos.